Thank you, ma'am. Without wasting much time, let's move on to the last session for today. I welcome the moderators, Dr. Lakshmi Sheshadri, ma'am, and Dr. Mary Daniel, ma'am. It gives me immense pleasure in welcoming Dr. Lakshmi Sheshadri, ma'am, to the program. We all know that Lakshmi, ma'am doesn't need much introduction. I'm sure that most of the students in South India follow ma'am's book only. And madam is a former professor and HOD of CMC Vellore. Currently, she is working as a senior consultant in Tirumala Mission Hospital in Vellore. And her areas of interest are gynae oncology and menopausal medicine. And she's working for the community level for cervical screening program and for postmenopausal osteoporosis. Next, I welcome Dr. Mary Daniel, ma'am. Madam is a professor and HOD of the Department of OBG in Pondicherry Institute of Medical Sciences. She is a member of the PG Board of Studies and Stem Cell Research of Pondicherry University. Her areas of interest are high-risk pregnancy and infertility. She has publications in international and national journals, and she has been awarded the Best Doctor Award by the Lions Club of Pondicherry and Tamil Nadu Circle. Welcome, Dr. Mary ma'am and Dr. Lakshmi Sheshadri ma'am. Now I ask the presenters to introduce themselves and proceed ahead with the presentation.
Good evening, ma'am. Lakshmi, ma'am.
Hello, good evening, and good evening, Dr. Mary.
I'm so honored to chair the session with you.
It's a pleasure. It's a pleasure. Yeah.
Madam, Lakshmi, madam, I'm Dr. Satikla from
Yes,
AVMC.
yes.
Welcome you, madam.
Thank you. And good to be there. I've been listening to the previous sessions and enjoying it. Yeah. Yes,
Okay,
I joined in after Aruna's at been around. Yeah. So good. So we have Nikita and Shafli. Okay.
Shafli.
Yes, Shafli. Okay.
Can you hear me, ma'am?
Yes, I can, but I can't see you. Nikita, is it? Who's presenting?
Nikita, ma'am.
Okay, fine. Right.
Yes, ma'am.
And Shafli, Shafli is also there, I guess.
Yes, ma'am. Screen.
Okay.
There's an issue with the screen.
Yes.
Okay, ma'am. Good evening. Start, ma'am.
Yes, please.
Good evening, ma'am. Today is my case presentation on hypoglycemia in pregnancy, and the primary presenter is Dr. Nikita, and my co-PG, Shaflia, will be my co-presenter.
Dr. Nikita, kindly make it a slideshow.
It is a slideshow, ma'am.
No, it's not, ma. Just change it to slideshow. Yeah.
Okay. No? It is in slideshow.
No. The slideshow. It's on
you have to close again, reopen and click on the slide. Then only it will go into slideshow. First you click on the slide and try to make it slideshow.
No, ma'am?
No, it is not. You have to close and open it.
Okay.
Or there must be some problem with your...
Just go to the top and click on slideshow. Or at the bottom and on the icon for slideshow. It will just happen. That's it. Yeah? Yes, exactly.
No, ma. You have to go here.
Say from the beginning. Yes.
No, ma'am?
Yes.
No.
Even now it is not there.
There must be something wrong with their...
Now it is all right.
Can you see now?
Just try to click on the slide and then try to put on slideshow. From beginning.
Okay. Yeah. Now it's showing.
Now it's showing,
Now it
ma'am.
has come. Now it has come.
Okay, ma'am.
Okay, it's come. Yeah, it's
Okay.
slideshow now. Yeah, right.
Okay. Good evening, ma'am.
Evening.
My case presentation is on hypoglycemia in pregnancy. I'll be starting. So, Mrs. X, age 28 years, wife of Mr. Y, residing at Kadlur, belong to lower middle socioeconomic status. She's gravida 2, para 1, live 1, at 23 weeks plus 5 days gestation age, belong to lower middle socioeconomic status. Was referred to AVMC after doing a screening test for GDM by DIPSI method with a value of 172 milligram per DL in a nearby PHC and was referred for further management. The screening test, which was done in the first trimester, was normal. LMP is 13,921 and EDD was 2622.
Yeah, go on.
She is able to perceive fetal movements well. No history of abdominal pain, no history of white discharge, no history of burning micturition, no history of polyuria or polydipsia, no history of bleeding PV, no history of blurring of vision or headache or epigastric pain or decreased urine output, no history of any excessive weight gain, no other specific complaints.
Okay. Now you have said no. No. Just go to the previous slide. Go to the first slide.
Yes, ma'am. The previous slide.
Yeah. Okay. Now you have said that she was screened for GDM by DIPSI method in the second trimester when the first trimester test was normal.
Yes, ma'am.
Now, what was the screening test done in the first trimester? Do you know?
Ma'am, it was same DIPSI method which was done over there, ma'am.
Okay.
There, the value was less than 140 milligram per DL. Again, around about 24.
One sec.
Yeah.
Less than 140. What does it mean? DIPSI. What are the cutoff values? It can be less than 140 and still be abnormal, right? So, what are the cutoff values with the DIPSI? It's a 75 gram 2 hour, right?
2
Is that
hours.
what you mean by DIPSI?
Yes, ma'am.
Okay. So, what are the values? What are the cutoffs?
Ma'am, less than 40 is considered to be normal, ma'am.
Less than
140, 140. Less than.
There is something between 120 and 140. What is that considered to be?
Impaired glucose tolerance.
Exactly. So it is not considered normal. So less than 120 is normal. More than 120 is impaired glucose tolerance of pregnancy. More than 140 is gestational diabetes. So what? So when I ask you what was the value in the first trimester, saying that it was less than 140 is not acceptable. You have to say what exactly it was, because between 120 and it can be less than 140, but more than 120, which means impaired glucose tolerance. So what was? Do you know what was the value? You may not. It doesn't matter.
Yeah, she was referred from a nearby PHC.
Okay,
So
saying that the first trimester was normal. Okay.
Yes, ma'am.
Now, if you have a first trimester screening test that is normal, when do you do the second trimester screen?
Ma'am, around about 24 weeks, ma'am.
24 weeks. And when
Yes,
was
ma'am.
this done?
23 weeks plus 5 days, ma'am.
No, that she's referred to you at 23 weeks and 5
plus
days. So
5
when
days.
was the test done?
Ma'am, she went around 23 weeks with the anomaly scan report to the PHC, ma'am. That time, DIPSI test was done.
DIPSI was done. So it was done a week earlier than usual, right?
Yes, ma'am.
Okay. Dr. Mary, do you want to ask?
If you get an abnormal screening test in the first trimester, anything else that you would like to do?
Ma'am, we will be doing the normal routine scan, ma'am. Dating scan will be checking out, but HbA1c also we will be doing, ma'am.
Anything else to know the
Screening test, Papa, and
type of diabetes that you want to know?
ma'am, HbA1c value greater than 6% will
HbA1c would also help to know if it's pre-gestational or not.
diabetes mellitus.
Okay, though it could be in the first trimester, it could help you document that. Be sure that it could be a pre-gestational.
Okay. So why do you do this? When do you normally screen for diabetes in pregnancy?
Ma'am, considering India is a very high risk. We are at high risk, ma'am. So universal screening is recommended.
We are at high risk for what?
We are developing diabetes, ma'am.
Diabetes. Okay, fine. Therefore,
so any woman who comes for the first visit should be screened for diabetes in pregnancy, ma'am.
Pregnancy. Okay.
Yes, ma'am.
So when you are screening in the first trimester, what are you actually looking for? Is it gestational diabetes or diabetes?
Pre-gestational diabetes mellitus.
Okay, you are looking for pre-gestational diabetes in the first trimester.
Yes, ma'am.
Why so? Why not
because,
gestational diabetes?
gestational diabetes.
Can I ask Shafali to answer? What's her name?
Yes, ma'am.
Shafia.
Yeah, please. Shaflia, is it?
Yes,
Yes,
ma'am.
ma'am.
Yeah, please. Can you answer? Why not? Um, why are we not looking for gestational diabetes in the first trimester?
Ma'am, because pre-gestationally, if the HbA1c is high and the patient is
No,
diabetic,
no, no,
it is
no. My
embryo.
question is different. Why is it that we say that in the first trimester we are only looking for pre-gestational diabetes, but
Because
not
the
just?
Sorry,
Yeah.
ma'am. Because the decompensation happens around 24 to 26 weeks, ma'am. So we will not look
Okay.
for pre-gestational diabetes in the first trimester. We
Why
go
does
for
it
the second.
happen so much? In the second trimester, why does it happen after
Ma'am,
Because of
24
the
weeks?
switch from maternal
compensatory to
carbohydrate.
decompensatory.
No, wait a
No,
minute.
what is
Let
the
her answer. Yes. What happens?
diabetogenic state cost?
Because there is a maternal switch from in pregnancy, ma'am. There is a maternal switch from carbohydrate metabolism for glucose to use of fatty acids.
When?
For
When? Is that
in
why?
the
Because there is a switch to utilizing
no,
fatty
ma'am. So
acids. It's why we are
basically, what is
testing in second trimester. No.
no, ma'am. So what happens is mother's body also produces enough insulin to counteract the hormones of the pregnancy. The
Okay.
hor-
Okay.
At around 24 weeks, even if we reach a decompensatory phase, where the mother's insulin level is not enough to counteract the
So does that happen
process.
in all women?
Ma'am, pregnancy is a state of insulin resistance, ma'am. But in case of diabetes, the insulin resistance increases because of the hormones, which
Okay.
acts as
So
a
now we are
anti-insulin.
talking.
Yes, ma'am. Which acts as a anti-insulin hormones, ma'am. For example, human placental lactogen, estrogen, progesterone. In spite of high increased insulin secretion, this cannot be compensated, and that will go for a decompensatory phase during the second trimester. So this change from compensatory to decompensatory phase happens in the second trimester, and that's why gestational diabetes mellitus is more common in the second trimester.
And also the fasting hypoglycemia.
Yeah. Yes.
What is the reason for the fasting hypoglycemia is what we expect in pregnancy. Not when we do not expect fasting hypoglycemia. So that could be the reason also why there is a fasting hypoglycemia. Okay, because of the peripheral hemodilution.
Yes, ma'am.
Okay.
Sorry, I think I lost you for a while. So tell me, why does it manifest in the second trimester? The simple answer is extremely simple.
Ma'am, because the body, there's a change from compensatory to decompensatory phase, ma'am.
No. The problem is that the levels of diabetogenic hormones of pregnancy actually, it's a very simple, straightforward answer.
Anti-insulin hormones increase, ma'am.
No. The levels of all the diabetogenic hormones of pregnancy start going up only after about 15 or 16 weeks, and they keep going up and become clinically significant. The levels become clinically significant around the 24 weeks. They keep going up till the third trimester, almost 34 weeks, and then plateau. And therefore, an abnormality in the glucose metabolism induced by the diabetogenic hormones of pregnancy actually begin only when the levels of these diabetogenic hormones are high. Now tell us, what are the diabetes? So it is not decompensation. It's not a cardiac decompensation we are talking about. We are talking about an abnormality which sets in. That's a very straightforward and primary answer. You cannot fumble on that answer. Okay. So now I'm sure you will answer, what are the diabetogenic hormones?
Ma'am, human placental lactogen, estrogen, progesterone, cortisol, tumor necrosis factor, somatidin inhibitors, interleukins.
Okay. Wait. What are the significant ones, important ones? Human placental lactogen, yes.
Tumor necrosis factor is the independent factor.
No. What would be the other important factor? Okay, it is actually corticoscopic releasing hormones, all produced by the placenta. What is the next one? It is a progesterone. Okay, then of course we have growth hormone. Then comes all the others, tumor necrosis, etc. Okay, so these hormone levels go up only in the second trimester. Now, what do they do? These do. Why is there an abnormality in the carbohydrate metabolism in pregnancy in the second trimester? These are all
Ma'am,
going up. So what happens? You said there is increase in the insulin resistance. Now, do you want to add to that, Chef Ali? Yeah. What are the other things that happen?
ma'am, placental insulinase, no, ma'am, that will
That's
destroy the
one of the
insulin.
last ones that happen.
There'll be
Yeah.
increase in hepatic glucose
There
production,
may
ma'am.
be an increase in the hepatic glucose output. Yes.
Then
Increase lipolysis.
increase free fatty acids that causes increase in
Yeah.
insulin
Why is there
resistance,
an
ma'am.
increase in the free fatty acid?
Ma'am, because the main aim of pregnancy is to transport maximum of the glucose to the fetus.
Yes.
So there will be to transport more glucose to the fetus. This is at the cost of less glucose to the mother. So they will
Not
break
really.
down triglycerides.
The fetus eats all the time. The mother only eats every now and
Every now
then.
and then.
So you please remember, when the maternal glucose levels, as in the night, in the fasting state, are not adequate, the fetus starts utilizing the fatty acid, the fats, and therefore fatty acid levels may go up. And this is the situation in the morning, which is known as what?
Accelerated starvation.
Accelerated starvation. And because of the fasting blood sugars in pregnancy are, the fasting blood sugar is usually low. Exactly. So there is a fasting hypoglycemia. And what happens after a meal?
Postprandial hyperglycemia.
Hyper, because the response to glucose is higher. There is also a higher response of insulin production, but there is increase in insulin resistance. Of course, these higher levels of insulin, they are destroyed by the placental insulinase, and therefore there is a overall insufficiency. And please remember, these are women who might later, stressed by anything, will develop diabetes, and therefore it's a forerunner of a type 2 diabetes. Therefore, now we know that it is the second trimester when we are going to test. We know why is they become abnormal in second trimester is what we have looked at. Now, in the first trimester, what are we looking at? You said that this lady, Dipsy, also says look at screen in the first trimester. Everybody says please screen in the first trimester. Why? If the levels of these hormones go up only in the first trimester, why are we screening in the first trimester?
To look for pre-gestational diabetes.
Absolutely. So in the first trimester, please remember, this is what you got to get into your head, that in the first trimester, you are looking for a pre-gestational diabetes. In the second trimester, we are looking for a gestational diabetes. But then people also confuse you by saying that if you do, Dipsy tells you, if the level is more than 120, it is a glucose intolerance of pregnancy. If there is no intolerance of pregnancy in the first trimester, why are we looking at it? It could be an unmasking of a pre-gestational diabetes that is happening, and a very, very minimal or mild form of pre-gestational diabetes that is happening in the first trimester with the lower level of hormones that are already present, maybe the progesterone and other hormones which are very mildly diabetogenic, and we want to know if any of this is abnormal or not. Now, okay, tell me, Mary, you want to ask something at this point?
It's fine.
What are the tests that you would use in the first trimester to screen for pre-gestational diabetes?
We'll be doing our basic FBS, PPBS, HbA1c, HbA1c being the main.
What is the cutoff?
Ma'am, less than 6, ma'am.
What is the cutoff?
Ma'am, 5.9 is the normal value.
No,
ma'am.
most the American, yes, 6.5. Somebody is answering. Yes, 6.5 is the cutoff. Okay, right. Anything more than 6.5 is considered diabetes. Less than there are people who recommend that you do a HbA1c in the first trimester. More than 6.5, treat as diabetic. Less than 6.5, screen again in the second trimester. Okay. Then what is the other thing you can use? People have used
FBS greater than 126 or RBS greater than 200 milligram per day.
FBS, you mean fasting plasma glucose. Okay. Or what is the fasting blood plasma? What are the cutoff values?
Greater than equal to 126.
Yes, that is diabetes. Okay. And if it is more than 95, or according to some, and 92 according to the others, it is
impaired,
indicative of a gestational diabetes. Okay, not impaired. Impaired comes in only in Dipsy. Okay. Now, or what is the other test that you can use? The third one.
PPBS,
blood sugar.
random PP2 or PPBS or random blood
Okay,
sugar greater than 200.
2 are postprandial. Do not use
blood sugar.
abbreviations in the examination. Okay. Do not use these acronyms. So 2-hour postprandial or a random more than 200.
200
Okay.
milligrams.
So if any of this is abnormal, grossly abnormal, they go into the diabetes, pre-gestational diabetes category. Mild abnormality like more than 95 fasting, or if you're doing a DIPSI, if it is anything more than 120 becomes a gestational diabetes. Okay, and if you've said that they are gestational diabetics, most people believe you don't have to actually screen because you would have started them on treatment anyway. If these are normal, you screen at the 24 to 28 weeks. Okay. Right. Now, DIPSI is what, I mean, there are innumerable tests that are available, innumerable guidelines. You have the American Diabetic Association, you have the American College, you have WHO, you have the IAD PhD, but in India, most examiners love DIPSI. So stick to it. You must know the WHO values, or how to do it, and what are the cutoff values. Okay. Right. Now, while we are at it, tell me, how do you do this DIPSI method of testing?
Irrespective of the last meal, the lady is in the morning when she comes, 75 gram of glucose is given to in about 300 ml of water.
150 to 200 ml of water or lemon juice. Okay.
And she's asked to take over 10 minutes, ma'am.
Okay.
And then after 2 hours, PPBS is done, ma'am. If the value is greater than
okay, the values. If she vomits,
ma'am, if she vomits within half an hour, we have to repeat.
Okay, fine. So you all know what is to be done. Fine, fine. Can we go on? Right.
Okay.
So this lady had a normal test in the first trimester and abnormal test in the second trimester. So she's well and truly a gestational diabetes. Okay, right. Go on. So are you all clear? I want to know if everybody is clear about screening. What are we screening for in the first trimester? What are we screening for later on in pregnancy? What are the tests that are used, and what are the value, and what are the tests that we use? Because if you try to remember all the tests that are done, you're going to be confused. Remember WHO, remember DIPSI, you will get through your exam. Okay, fine. Now go on.
Ma'am, history of the present pregnancy, ma'am. In first trimester, patient conceived spontaneously and was confirmed after 45 days of amenorrhea. No history of hyperemesis gravidarum. No history of fever with rashes. No history of bleeding PV.
No, one sec. Just go to the previous slide. Sorry, I was going to ask you some questions on that. Yes. Yeah. Now, you said no abdominal pain, no white discharge, no burning micturition. Why? Anything in particular? She's just 24 weeks pregnant.
Ma'am, a patient who are GDM are more prone to urinary tract infections and candidiasis because
GDM. I mean, I would have thought that infections are more common in
pre-gestational
diabetic. Those with gestation, gestational diabetes are not. And anyway, why abdominal pain? I mean, you could always say no history suggestive of a urinary tract infection. Because when you say abdominal pain, I'm thinking of preterm labor. I'm thinking of threatened miscarriage. Why? I mean, the thing is, you want to call a spade, call it a spade. Okay, do not go round in circles. Then you're looking for symptoms of urinary tract infection. Okay, why white discharge?
Ma'am, candidiasis.
Okay, right. Why polyuria, polydipsia? You know she's a gestational diabetic and she's not going to present with any of these symptoms. Why bleeding PV?
Yes, no reason.
Just like that, obstetric patient. So I better ask this question. Okay. No blurring of vision, headache, epigastric pain. Oh, at 23 weeks of pregnancy. Why?
Ma'am, because in cases of
now
GDM,
they are more prone to hypertension, therefore they are more prone to
preeclampsia,
and they are more prone to eclampsia. Come on, man. Come on. Okay. So if you're presenting somebody, you have not even said whether there's any history suggestive of a hypertension or blood pressure was high or not. When the blood pressure was high, you would have mentioned it in the history. She only was referred because of her abnormal glucose tolerance, and therefore you could say hypertension, but to go to this extent of calling, giving symptoms of impending eclampsia is not warranted. Excessive weight gain, maybe go down. What is the other one?
No other specific complaints, ma'am.
Okay, so basically what you're trying to say here is no symptoms suggestive of urinary tract infection, no history of a hypertension antedating the pregnancy, and no abnormal weight gain. I agree, but the others I don't. Okay, Right. Okay. Go on. See, when you present all this, you will get into trouble, and especially if you bring in symptoms of eclampsia and threatened, whatever imminent eclampsia here, I think it is really unwarranted. Not at 23 weeks. Okay. Right. Okay. Go on.
History of present pregnancy. In the first trimester, the patient conceived spontaneously and was confirmed after 45 days of amenorrhea by UPT. No history of hyperemesis gravidarum, no history of fever with rashes, no history of bleeding PV, no history of any exposure to radiation, folic acid supplementation taken, and the screening test for diabetes that was done in the first trimester was found to be normal.
Mm. When was her first visit, may I ask you?
Ma'am,
At what period of gestation?
Actually, since she is a referred case from PHC, we are not sure of the dates, ma'am, but she was referred here at 23 weeks.
No, but then she told you that you have asked her a whole lot of questions.
Around about 9 weeks, ma'am.
Exactly.
Because
you could have asked her easily. When you could get all this history, you could have also asked her when was your first visit. Okay, right?
Okay. Then the blood investigations which was done in the first trimester was normal. HP was 10.2 gram per dl.
Fine. Okay.
Dates corresponding according to the dating scan, ma'am.
Okay. No, so you know that she has definitely gone. Why? What else would you look? Why are you doing a dating scan? Do you do it in everybody, all your pregnant women, or is it done with a purpose?
Ma'am, we have to confirm dates, like in case the periods are irregular, in case of PCOS syndrome.
But her periods were regular, right?
Yeah, in her the periods were
so
regular.
Then when would you do a first trimester scan, if at all you want to?
7.
Is it at 9 weeks?
7 to 9.
Is it at 7 to 9 weeks? You want to do a first trimester scan in everyone?
You want to combine it with
11 to 13 plus 6.
Absolutely. You can, your gestational age accuracy is more or less the same as at 7 to 9 weeks, and you also get additional details. So if you're doing a first trimester scan, the current recommendation is to do one between 11 and 13 plus 6 weeks. So why one is done at 9 weeks, I'm not very sure about. But if you knew that there was this history, or if you knew that she had a pre-gestational diabetes, is there any reason why you would do a first trimester scan?
Anencephaly, ma'am, to rule out anencephaly.
You could. And what else? What else would you like to know? Why is a scan mandatory in these women? A first trimester scan with pre-gestational diabetes.
We have to be very sure of the dates, ma'am.
Because they may need to be
delivery.
induced or delivered early if the sugars are not under control. Of course, some anomalies like this thing you can certainly make out by a first trimester ultrasound. So is there, okay, right, that's fine. Go on. Dr. Mary, you wanted to ask something, right?
It's okay, ma'am. It's fine.
Okay, go on.
Go ahead.
Second trimester was able to perceive quickening at 18 weeks. She was fully immunized against tetanus. Iron and calcium supplementation were taken. BP recording done in the nearby PHC was found to be normal. Anomaly scan done at around about 20 weeks was found to be normal with no congenital anomaly noted. Screening test for GDM was done at 23 weeks plus 5 days, where GCT was found to be 172 milligram per DL and was referred here for further management.
Okay.
Coming to the menstrual history, her LMP is 3921. Her previous cycles were regular, lasting for about 5 days in a month, and she changed about 3 pads per day associated with moderate flow, ma'am. Marital history, she's married since 6 years, non-consanguineous marriage, ma'am. Coming to the obstetric history, she is gravida 2, para 1.
How old is she?
28.
Okay.
Her first delivery was a full-term normal delivery at Kadlu GH. It was spontaneous conception after 6 months of marriage. All trimesters were uneventful. No history of GDM or hypertension disorders in the pregnancy. It was a female baby weighing about 3.1 kg and it is 4 years old now. Postpartum IUCD was inserted and it was removed after 3 years, ma'am.
How did she deliver?
Normal delivery, ma'am.
Full-term
normal delivery.
Where was, okay, FTM.
In Kadlu
okay, fine.
Past history, not a known case of type 2 DM or hypertension or asthma or thyroid or epilepsy or tuberculosis. Not a known case of polycystic ovarian syndrome. Family history, mother is a known case of type 2 diabetes from 10 years and on medication. No family history of hypertension noted, ma'am.
Okay.
Personal history, diet mixed, bowel and bladder movements normal, appetite normal, sleep pattern is normal, ma'am.
Okay.
Then coming to the summary, Mrs. X, age 28 years. She is gravida 2, para 1, live 1 at 23 weeks plus 5 day gestation, was referred from a nearby PHC as a case of gestational diabetes mellitus with a GCT value of 172 milligram per DL with no previous history of GDM. and was referred to AVMC for further management, ma'am.
Mm-hmm. Okay.
Coming to the general physical examination, the patient is moderately built, not anemic. The height is 160
Well, 1 minute. Stop here. Dr. Mary, you want to ask them anything at this point? They've just completed the history.
How did you find out that she was not a gestational diabetic last time? Anything else?
Ma'am, ma'am, the previous PHC notebook which we had, ma'am, those investigations and whatever was mentioned,
But
that
you
didn't.
don't get the notes at the exam time, no? You are supposed to take history. You are not seeing the reports. No, you should take the history.
She told that she didn't have any comorbidities, ma'am, when asked retrospectively.
Okay.
Does she have any risk factors for diabetes at all?
Ma'am, family history of type 2 diabetes mellitus is there, ma'am.
Yes.
Then she's moderately built, ma'am. Her BMI is around
No.
27. Not that. Nothing other than that. No other significant history, ma'am, for high risk.
Okay.
Oh God. Yes. Is it considered to be normal? BMI of 27?
No, ma'am. According to New Indian, it is obese, ma'am. It is on the obese
Yes,
side.
it is obese. So then she does have a BMI. Yes, okay, which is higher than normal. Yes, because any BMI more than 25 is considered to be an indication for. Yes, okay, right. So she has a family history. She has a BMI which is more than 25. All right, and age, she's 28 years of age, and of course she is an Asian. Okay. So in addition to the fact that she's Asian, she has all these risk factors, and therefore testing becomes mandatory. And with the same risk factors, she could have had gestational diabetes last time, and I think it is important to ask. Okay, right,
Yes,
Dr. Mary. That's what Dr. Mary was stressing on. Yeah, okay.
General physical examination, the patient is moderately built and not anemic. The height is 160 centimeter and pre-pregnancy weight was 63 kg and the present weight is 69 kg and the BMI calculated at present when she came was 27.2 kg per meter square.
Okay.
The
How much weight gain do you allow her? Would you allow her with a BMI of 27.2?
Ma'am, actually, with the obese, 1 minute, ma'am. 5 to 9 kg, ma'am.
5 to 9 is too little. That is for those with a BMI of about 30. So those who have a morbid obesity.
Ma'am, there's this less than 18.5 is 13 to 18. 18.5 to 24.9 is 11 to 16. 24.9 to 29.9 BMI, according to the BMI, ma'am, is 7 to 11 and greater than 30 is 5 to 9. So 7 to 11. 7 to 11.
Exactly. So exactly. So she's not greater than 30. She is 27.2, right? Yeah. Okay.
Yes,
so we all that you need doesn't matter. You need not remember. You have to remember it for the exam. I'm not particular, but you should know how that you would allow, definitely not allow the usual weight gain of 11 to 13 kg. It would be much less. Okay. So her weight gain so far has already been 6 kilos. Okay, go on.
The pulse rate is 86 beats per minute and
Fine.
the BP is 120 by 84 beats per mm of HD, sorry, ma'am. Thyroid normal, bilateral breast soft, non-tender.
Yeah. Yes, go on.
Systemic examination.
Yeah, fine. All normal. Go on.
Nothing significant. Per abdomen examination, inspection, lower abdomen appears to be distended. Linear nigra and stria
That's fine. That's fine. Palpation, what did you find?
Uterus corresponds to 24 week size, ma'am. Fetal parts felt. On auscultation, FHR is 142 beats per minute.
Okay.
Then diagnosis, she's a 28-year-old patient with gravida to para 1 Lipen at 23 weeks.
28-year-old lady.
28-year-old.
Okay.
At 23 weeks plus 5 days gestation with gestational diabetes mellitus, who is normotensive and no previous history of GDM, and was referred to AVMC for further management.
All right. Okay. Dr. Mary, you want to take it?
Normotensive, do you have to specify if she is hypertensive? You specify, but otherwise not necessary to mention normotensive. And also not a known case because we are not excluded that she's gestational with no previous history of gestational diabetes. Not necessary to mention that. If she had it, you will tell. Here you have not excluded, you are not sure. If she delivered with you or you had a proper record, then probably you could put it.
And her having a previous history of gestational diabetes or otherwise is not going to influence the current management either.
Only a risk factor to check.
Okay. So how would you, she's 20, Dr. Mary, you want to ask the question?
No, ma'am. Yeah.
She's 23 weeks pregnant, 23 plus 5 or whatever. How would you, Chef Leah, how would you
Yes,
proceed?
I would like to proceed by asking her to get an OGTT done, ma'am.
Okay. What kind of OGTT will you do?
Ma'am, I will ask her to take.
No, there are two types of OGTTs, right? Which one would you like to do?
Single step.
Single step, ma'am.
Single step, but what OG? Single step is, that is type testing for
With 3
glucose
days,
or
I would ask the
abnormality.
patient to consume a normal diet for 3 days, ma'am.
No, all that is fine. Which one? There are two OGTTs available. You know or not?
Ma'am, single step method and double step method.
No, that is not OGTT. In single step, you do an OGTT straight away. In double step, you do a
GCT and
glucose
OGTT.
challenge followed by an OGTT. That's fine. But I want to know which
The
GTT will you
75
do.
gram,
People are
ma'am.
already
75
answering. Yes,
75
exactly.
gram.
It could be a
75
75 gram or it
Or
could be a
50 gram.
50 gram.
right.
No,
100, 100.
GTT, glucose
50 gram is a
tolerance
test.
100,
test.
100, 100.
100 gram. Look, you cannot be. I agree. This glucose testing, I mean, I am also very bugged with it because it's so confusing. But please, you're going for your exam. Be very, very sure in your mind. A 50 gram testing is a glucose challenge
Challenge
test.
test.
A GTT can be only one of
100.
two, either a 75 grams
75
and 2
gram or
hour
100 gram.
or a 100 grams and a 3 hour GTT. Okay.
Yes, ma'am.
The 1 step and 2 step are two methods of screening. In a 1 step, you do a GTT straight away. In a 2 step, you do a GCT challenge test. I don't like to call it a challenge test followed by a glucose tolerance. Is
Glucose
that
tolerance
clear?
test.
So please
Yes,
don't be confused in your answering. Okay. Right. So which, Chef Leah, which testing?
Screening and
I would ask
confirmatory
her.
test.
I would
Sorry?
ask her to get a 75 gram
Screening
2
and a
hour.
No,
confirmatory.
Dr. Mary is saying something. 1 minute. Yeah, Dr.
Sorry.
Mary.
We call this as a confirmatory test. Screening and confirmatory test.
Are you going to do a screening or confirmatory?
Confirmatory test.
Confirmatory. Which one would you like to do?
I would like to do a 75 gram oral glucose tolerance test, ma'am.
Okay, this is as recommended by
International IDAPSG, ma'am.
Association.
And
WHO, basically. That's what you
WHO.
need to
Yes,
remember. Okay. Yes.
So I would ask the patient to take 3 days of normal diet, and then I would ask her to come to the
Yeah, usual 75. What are your cutoff
70.
values?
92, 180,
fasting 92, ma'am. 1 hour 180 and 2 hour 153.
153.
Any one value is abnormal, we would label
You
her
are
as
going
GP.
to, okay, right. So you're going to do this test in this lady. And what are you going to do after that? If one value is abnormal, which it is more likely going to be because she's got an abnormal DIPSI testing. Now, what are you going to do?
Ma'am,
No,
we'll
Chef
label her
Leah
as
is answering. No, I want her to answer.
I would
Yeah.
ask her to I would advise her to take MNT, ma'am. Medical
Sorry?
nutritional therapy.
Medical nutritional therapy.
For 2
Okay,
weeks.
right then. What
For
would
2
you?
weeks,
How
ma'am.
much carbohydrate? How much protein? How
50
much
to
fat?
60% of carbohydrates, ma'am. 20
Okay.
to 30% of proteins, and 30% of
Okay,
fat.
almost
of which
40%
less
of fat now.
fat,
Okay.
of which less than 10% should be saturated fat.
Okay, and in what pattern would you give her the diet?
I would split the diet into 3 normal main meals, ma'am, and 3 snacks.
3 meals and 3 snacks. Okay,
three
2
snacks.
to 3 snacks. Okay, fine.
Yes.
All right. Okay, and then what do you do? She has taken all this.
After that, I would also advise her to do advise her exercise, ma'am, and I would ask her to come after 2 weeks, and I would ask her to get an FBS and
2 hour
fasting blood sugar and 2
And
hour
a 2 hour postprandial.
Yes,
Okay,
ma'am. Of
right.
which,
Okay, fine. So, if these after medical nutritional therapy, let us say her values become quite normal. Her fasting, what do you want the fasting to be?
less than 92.
Yeah, sorry, Dr. Mary.
No, the target values.
Yeah, target values.
120. Fasting less than 92, ma'am, and 2 hour postprandial blood sugar should be less than 120.
120. Okay, that's a target. So let us say they've all reached the target values. How are you going to manage her subsequently?
I would ask her to continue the nutrition therapy, ma'am.
Okay.
And I would ask her to come every month
Monthly once,
monthly
ma'am,
once I
as
would check
high
her
risk
sugar
pregnancy.
values.
Okay. Okay. Then she's reached third trimester. I want to know specifically, will you repeat a GTT in the third trimester?
Yes, ma'am.
Would you? Would you?
Yes, ma'am. Yes, ma'am.
Yeah. A lot of people. Dr. Mary, you are going to say something?
She's already on the diet.
No.
We have
We
to
still
repeat,
have to
ma'am.
repeat, ma'am, at
There,
32
if
to 34 weeks.
you are again confused, if the GTT is normal in the second trimester, many advise repeating it, especially in Indians, and there are this American college, there's some recommendation, you repeat it in the third day. You already have an abnormal test report. What is the point in repeating it and saying, yes, yes, it is abnormal? Is it going to be normal? If you
Ma'am,
put
if
her on a
MNT
very
is,
good diet and
MNT is
medical
working,
nutrition therapy, it may be normal. But if she's not following, it's going to be abnormal. How does it matter? You are testing her fasting and
Yes, ma'am. I will.
so
Then I will.
again, please do not be confused. A repeat OGTT in the third trimester recommended only if the second trimester screening is normal.
No.
Do you understand? Otherwise,
Yes,
that is why I wanted to know whether you walk into my trap and, and say, yes, yes, I want, you already got somebody with a positive test. So she's on all this. Right. Now,
Then
what
I would ask.
complications do you expect in her, ma, Nikita?
Yes, ma'am. And
She's a gestational diabetes well controlled on medical nutritional therapy. What complications do you expect?
ma'am, patient who are on who is
Gestational diabetes on controlled on medical nutritional therapy.
Macrosomia.
1
minute, ma'am. Ma'am, if it is well controlled, then
yes,
nothing.
Absolutely. They actually do very well. The risk of macrosomia, hypertension, all other problems are almost the same as in the non-diabetic or non-gestational diabetic, and therefore they can be managed almost like non-gestational diabetics, except that you keep you do screen them around say 32 weeks again to see if there is a macrosomia, and keep monitoring their blood pressure. These are the two things that you're worried about. But regular 2 weekly fetal monitoring, weekly fetal monitoring, etc., third trimester, biophysical profile, early delivery, nothing is indicated. They all can be delivered at what period of gestation?
Ma'am, if there's not complicated, 40 weeks.
Look, we are talking about do not bring in the class. A non-complicated gestational diabetes on medical nutritional therapy well controlled. You can deliver at 40 weeks. Now, put that aside. Let us come to the next category. This same gestational diabetic, you put her on medical nutritional therapy and the sugar did not come under control because her OGTT values were much higher. Okay, her fasting on OGTT was 110. Her postprandial was 178, etc. So what is your management? Dr. Mary will take it. I'll just drink some water.
What are the complications you can expect in an uncontrolled beyond the target values?
Ma'am, it is divided into maternal and fetal complications, ma'am. Maternally, there will be more risk of miscarriage, polyhydramnios,
miscarriage,
labor.
Ma'am, in labor you're asking.
You're bringing in miscarriage.
No, sorry, ma'am. Sorry.
Pre-gestational.
There's more chance of polyhydramnios, pre-eclampsia, preterm delivery.
Expect from the second trimester, you have to tell. Okay.
Polyhydramnios, pre-eclampsia, preterm delivery, hyperglycemia, and sometimes if it is not controlled, it will go to ketoacidosis.
Gestational diabetic, wait a minute. A gestational diabetic goes into ketoacidosis?
Ketoacidosis will not go.
Who is prone to ketoacidosis? Pre-gestational type 1 diabetes. Okay, not even a type 2 diabetes. All right? Okay, right.
Then in labor, there will be, because of the macrosomic baby, there will be shoulder dystocia, prolonged labor, instrumental increase.
We'll go on to that after, during the delivery. This is what you expect in this pregnancy. Okay. In the second trimester when you see her. Okay. These are complications when the values are uncontrolled. Okay.
Okay. Now,
not control, what do you do?
Ma'am, the first line of management is always insulin, ma'am. So we will be starting the patient on insulin, ma'am.
Well,
Any other
this
school of
lady,
thought? Any other
sorry.
school of thought?
Ma'am, according to 2015 NICE guidelines, they tell metformin is the first line of drug, ma'am. But in pregnant women, insulin is the treatment of choice. It's the first line of drug, ma'am.
Is that what does the Ministry of Health and Family Welfare tell you? That you can, insulin
It is
may be the
about
first
20
line,
weeks.
but you can also use
About 20 weeks.
Metformin.
about
Metformin.
20 weeks, and she's already 23 weeks, and metformin can easily use. Therefore, insulin, please remember, how do you weigh the benefits and risk of insulin? What are the disadvantages of insulin?
Ma'am, there is weight gain in case of insulin, and
Is that the most important? You are working in a rural area, let us say.
ma'am,
You are
the
working in wherever you are working. Yeah. So tell me
Hypoglycemia,
your
ma'am.
patient you think of. What are the problems of insulin?
hypoglycemia, the compliance,
No.
ma'am, less compliant,
Yeah.
less
Yes.
compliant, and
What
more
compliance?
cost,
Yes.
more cost.
Cost. Then what else?
Then storage.
Exactly. The practical difficulties, storage, administration. Both these are problems. Your average patient who comes to see you in your hospital, you think they're all the insulin kind, regularly insulin taking kind? No. We are in India, so we cannot go around saying that insulin, the textbook description of insulin is a drug of choice, doesn't apply to us. So you will decide on whether she has to take insulin or oral hypoglycemic agents depending on the patient. Okay, and if she is the type who would be compliant, who would understand the self administration, she has facilities for storage, she is you might want to give her a
Metformin, oral hypoglycemic
yes,
agent.
oral hypoglycemic agent. So the disadvantages are storage, administration, cost, compliance, and what else? And of course, you told us weight gain and hypoglycemia if she doesn't eat on time. So when all these disadvantages are there, and you know that the outcomes are more or less the same with oral hypoglycemic agent, I think you should be able to. You cannot categorically say, okay. So your answer should be you will choose depending on the patient. Now, what oral hypoglycemic agents are available, are used in pregnancy?
Metformin and glyburide.
Glyburide. Now, Chef Leo, you want to tell us how one compares with the other?
Yes, ma'am. Metformin is preferred over glyburide because
Why?
it has lesser incidence of, it causes lesser maternal weight gain. It causes lesser incidence of macrosomia and a lesser incidence of
neonatal
hypoglycemia.
Fine. Okay. But it also, yes, more people might require additional insulin. Then that is a trade-off. Okay. So in this lady, depending on also there are some guidelines which tell you that if the fasting is more than 110, insulin may be, even the Ministry of Health and Family will tell you that if the fasting is high, metformin or oral hypoglycemic agents may not be adequate, or you may not be able to get a good control, and therefore you will probably require insulin. So the decision to start insulin depends not only on the patient characteristics but also on the actual blood sugar values, especially a fasting of a lot of people give 110 as a cutoff. Okay. Yeah, Dr. Mary, you are asking.
How will you monitor the pregnancy? What else?
Ma'am, according to the national ministry.
She's coming to you for, you told us the visits that she should be taking. Then what else you will do in the visits?
Ma'am, when she comes, once we start her on medical nutritional therapy or exercise, we will do the fasting FBS and PPBS to her after 3 days, ma'am. If
3 days. 3 days is a short time.
Ma'am, 3 days if she was on insulin, bi-weekly if she is on
No. After you started on medical nutritional therapy and this, yeah, okay.
2 weeks.
Okay.
Yeah.
After 2 weeks, we will be.
After 2 weeks of diet or medical MNT, and then after 72 hours of your oral or the insulin therapy. Okay, pharmacotherapy. All right, and then?
That is for the class, GDM class A or B. If they are they are A.
A. Without any medication, A.
Without any medication.
A2 means with medication or insulin.
Yeah.
Okay. So these
A1 or A2.
two will require more monitoring, na?
Yes, ma'am.
Then what else?
Ma'am, we'll be doing MNT and physical exercise, ma'am. Then
Yeah.
we will be doing after 2 weeks. We'll be looking for the 2-hour postprandial blood sugar, ma'am. If it
Okay.
is less than 140, we'll ask her to continue the same 120. Sorry, we'll be asking her to continue the same MNT and exercise. If it is greater than that, we have to start the patient on insulin or oral hypoglycemic drug.
Yeah, that we
according to
have
the
already
compliance.
said. You have this lady, the first lady responded to medical nutrition therapy. This lady has not responded, and therefore you have decided to start her on pharmacotherapy, which is either insulin or OHA, which we've decided. We've already said what are the criteria. Having started on insulin or some kind of a pharmacotherapy, I want to know, ma'am wants to know how you will monitor.
Ma'am, we'll be doing the fasting, post breakfast, post lunch, and post dinner. We'll be monitoring the blood sugar, ma'am.
Okay.
And according to the insulin, that insulin
Okay,
values
and then
will
you
be
will adjust
titrated.
the insulin. How will you monitor the pregnancy, the mother and the fetus? Apart from, you will check blood sugars very frequently and you will adjust the dose of insulin or OHA accordingly. Apart from that, mother and fetus, sorry.
What kind of insulin will you give?
Regular insulin, short-acting insulin.
Only?
Initially we start with short-acting insulin, ma'am, and after that we switch off to
insulin. When will
mixed
you
start.
give short-acting insulin?
Sorry, ma'am.
When will you give short-acting insulin?
When postprandial blood sugar is
When
elevated.
postprandials are high, you will give the short-acting. When will any intermediate?
Intermediate is when fasting is high. Fasting
fasting
So
is
you
high.
have a fasting which is high.
You will use it.
Okay, you will be giving. Okay, then.
So what is the maternal fetal monitoring?
Ma'am, we will be sending her investigations again.
Yeah. When will you start monitoring the fetal? At the fetal monitoring, when will you begin?
32 weeks.
Around 32 weeks, especially to look for macrosomia.
Macrosomia polyhydramnios.
All right. Now, subsequent management. How will you monitor?
Ma'am, we start antenatal fetal surveillance at 32 weeks, ma'am. NST biophysical profile is done bi-weekly, ma'am. And the scan is reported.
You are, for somebody who's on a small dose of some 8 units of insulin in the night and 4 units in the morning, or metformin 500 milligram twice a day. Are you going to do twice a week?
No, ma'am. If they're controlled, no, ma'am.
Okay, so your
Once in
answer,
15 days.
there is no textbook description of how of the frequency of monitoring. Your answer should be the frequency of fetal monitoring will depend on the level of blood sugar. Okay, if the sugars are controlled with the oral hypoglycemic agents or insulin, you could monitor. You could do a baseline one at 32 weeks. You could repeat one, say at 36 weeks, and then depend on whether you want to do it. I mean, you can decide whether you want to do it weekly or not till delivery. If the sugars are not under control,
28
you will definitely monitor more frequently. This kind of an answer is quite sufficient, because you will not be able to say which patient and when, and it all depends on the blood sugar level. Right. When will you deliver?
Mama,
Now, I'll tell you, no macrosomia. Sugar controlled on insulin. When will you deliver?
Controlled on insulin, 38 weeks.
Around 38 to 39 weeks. Let us say the sugars are very difficult to control on insulin and there is a mild macrosomia. Okay, baby is big.
Ma'am, 37.
Around 37 to 38 weeks. Okay, when it's well controlled, 38 to 39 weeks. Very arbitrary. You should remember that requiring only medical nutritional therapy, deliver at 40. Do not allow them to go past. If it is well controlled on insulin or OHA, deliver at 38 to 39 weeks. If they are not controlled or have a complication, deliver earlier, anytime from say 36 or 37 to 38 weeks. Okay. Now, this lady, when she was tested in the first trimester, okay, she came and told you that when she had a test done in the first trimester and her DIPSI test was same 173 in the first trimester at 8 weeks of pregnancy. How is she going to be different from the patient that you are dealing with? You must, okay, I will split the question. What are the complications you expect in addition to the list that you gave me earlier?
Congenital anomalies.
Congenital anomaly. Number 2.
Then still miscarriage.
Miscarriage and
stillbirth, preeclampsia,
okay,
perinatal loss.
Okay, perinatal loss is there with everybody. All gestational diabetics are the so-called unexplained perinatal loss is there, but of course, much more. So miscarriages, congenital anomalies, yes, and
Preeclampsia.
preeclampsia and infections. Okay, and if she's a type 1 diabetes, also add ketoacidosis.
Acidosis.
So these are basically, of course, she will have macrosomia, she can get hypertension, she can have all polyhydramnios and various other preterm labor, etc., etc. So remember, between, therefore, how will you manage her? She is 8 weeks pregnant, has come to you with an abnormal DIPSI. What is the management? Yes, Shafali, you want to take it?
Yes, ma'am. 8 weeks gestation. Then I would ask her to get an HbA1c level, ma'am. And I would like to know her HbA1c level and her fasting blood sugar level. And depending on the HbA1c level, I will take further.
Ma'am, the aim is to
What
keep
are you going to do with the
HbA1c less than
HbA1C level? I
6%.
agreed and I waited. But what can you do with it? You will only know what the control has been prior to that.
Yes, ma'am.
She's
But
not
if
going to
the-
tell you anything else.
if
So
it is,
you need her
if the
fasting and her
HbA1c is high,
postprandial.
ma'am, it is indicative that she has been
Fine,
to
it is
congenital
indicated.
anomaly.
I agree with you completely. But you can't do much with that HbA1c. You
Then
can
I can
manage.
explain to the patient, ma'am, the risk of the pregnancy and the risk of anomalies in the baby. And depending on that, I could.
What is the HbA1c level that is associated with a high risk of congenital anomaly?
Ma'am, if it is 6,
More than?
8.
More than 8? No. It's, in
10
fact,
or
it is
12,
more than
ma'am,
10.
sorry.
Please understand there is no direct correlation between the level of HbA1c and the risk of congenital anomaly. But if it is more than 10, of course, the risk is much higher. So you
higher.
can't use this value for anything. The HbA1c will just tell you that the last 3 months the control has not been good. If the control has not been good in the last 3 months, what is it that you are worried about? And therefore, it has not been under control in the past. So what is it that you will look for at 8 weeks?
Congenital anomalies.
No, congenital anomaly, yes, ma, but that you can't make out anything now. What is, you're not worried about the mother? She's come to you
Yes,
with
ma'am.
the HbA1c, which is a very high, 8.5.
Ketos.
Yes, ma'am.
She has not been under control. You want to know whether she has a nephropathy. You want to know
Or an
whether she has a
NDMS,
retinopathy.
neuropathy.
I'm not going for exam. Okay, you are. So whether she has a retinopathy, a nephropathy, whether these are going to get worsened. So these are the things that you will counsel her about. So now what will you do at 8 weeks when you see her? You will check her
Ophthalmoscopy.
eyes. Yes, you will do a
RFT,
you will
microalbuminuria.
do a creatinine, you will do a urine microalbumin, you will also, okay.
Echo.
So you will do all these testing so that you know that she is fit to go through this pregnancy and how much complication you should anticipate. Now, after that, what will you do? You will definitely do the scan at 8 weeks, I mean at 11 to 13 weeks.
plus
And
6
yes,
weeks.
okay.
Anomaly scan.
And then anomaly.
Targeted
What are
scan.
the anomalies that you will look for when you do a targeted scan?
Fetal echo, ma'am. Like,
Hey, what are the anomalies you
scan.
will look for when you do a targeted scan?
ma'am, serious abnormalities, endocrinal cushion defect like VSD, ASD,
Cardiac,
transposition of
cardiac,
neural,
skeletal,
neural
okay.
defect,
Okay.
GI
Okay.
defect,
Fine. Okay. You will look for
Renal
cardiac,
anomaly.
skeletal,
and
okay.
kidney.
Oh, fine. So you will look for all these anomalies, and then of course how will you manage her? Now from now on the management matters. This is when let us say she has been on she comes to you and she says, I have been on glyburide before I started pregnancy. What would you do?
We should switch to insulin, ma'am.
You have to. Pre-gestational diabetics have to be switched to insulin. We don't manage them on water. Let us say she's also a hypertensive and she told you that I'm on various medications. So what will you do about them?
Ma'am, if she is on angiotensin converting enzyme inhibitors or ARBs,
So
we have to
these
stop it and
answers should
switch
be
it off.
spontaneous and you should not wait for me to ask you. So if a pre-gestational diabetic comes at 8 weeks, the answer is I will check all this. I will look for hypertension. I'll check all the other end organs for damage. I will review her medications and etc. etc. Okay, and then I will manage. All right. So then what are you?
Thyroid also will be checked.
Yeah, thyroid
Autoimmune
function test.
thyroiditis.
Okay.
I
Now
would
that
start her on
yes,
low
you
dose
started
aspirin also,
absolutely fine. So you will check her eyes. You will check for renal function test. You will review her medication. You will switch to insulin. You will look at the antihypertensives. You will manage everything. Okay. You will look for anomalies, targeted scan at 20 weeks. Now, how will you manage? Subsequently, how are you going to manage a diabetes? You said you're going to switch to insulin. You tell me what insulin will you use?
Ma'am, first we'll start with the regular insulin, ma'am.
Okay.
Short acting. Then
Okay.
then we'll be doing four time monitoring, ma'am.
Okay.
In case if it is not under control, we will be adding intermediate acting insulin also, ma'am. And then we will be monitoring her, ma'am.
Fine. So you start with short acting, and subsequently once you have brought it under control, switch to a combination of intermediate acting and short acting twice a day, which is has highest compliance. Okay, and add in the short acting only if post meal is high. Okay, if the post lunch is high, add increase your short acting with the breakfast. If the post meal dinner is high, you increase the short acting with dinner. If the fasting is high, increase your intermediate acting insulin. How about the newer insulins?
Ma'am, newer insulins, Detrimer.
Yeah. How about them? Will you use them or no?
Yeah, ma'am, we will use ma'am Lispro as part of the short acting which has come, ma'am.
How about the long acting?
Glargine.
Will you use all of them? What is the current recommendation? Yes.
Current recommendation is regular acting insulin and NPH.
Yes, current recommendation is NPH, and if regarding the newer insulins, you can use the short-acting ones, but not the glargine and the other long-acting, intermediate-acting ones, because they are not found to be. I mean, they have not been tried long enough to say whether they are safe or not. So this is the insulin management. Okay. Now, how about maternal fetal monitoring? Quick, we have only 5 more. Oh, no. How much do we have? Time? Oh, we have time. Okay. So remember that this is the insulin management is a combination of intermediate acting and short acting, and a third dose or even a fourth dose of two doses basically, but a third or a fourth dose of short acting is given if the postprandial sugars do not come under control. Newer insulins, the short acting can be used, but the long acting safety has not been decided, has not been proven. Okay. Now tell us, Dr. Mary, maternal fetal monitoring, whatever you want.
Yeah. What are the maternal fetal monitoring? How do you do?
Ma'am, ultrasound, ma'am. From 28 weeks, 32 weeks, 36 weeks.
That's not maternal. We are looking for maternal.
Ma'am, we'll daily fetal movement, NST, biophysical.
NST you cannot do daily or weekly from that.
Weekly, once in 15 days, ma'am. Ma'am, then maternally she should be checked for BP. RFT should be checked.
Yes.
Our RFT should be checked, ma'am. Urine culture to rule out any asymptomatic
bacteriuria. Yes.
Then fundal examination.
Okay. Should be done at periodic intervals. Yes. You should keep a watch on her creatinine as well. Blood pressure, very, very particular. Okay. Now come to fetal monitoring. Yes.
Ma'am, fetal monitoring is again, if it is pre-gestational diabetes, antenatal fetal surveillance will start from 28 weeks. If it is gestational, then it will start from 32.
No, forget gestational, we've discussed. Now talk only about pre-gestational.
Ma'am, regular scanning is done from 28 weeks, 32 weeks, 36, at 4th weekly interval, ma'am, to look for any macrosomia, polyhydramnios.
So is it written in stone that you will only monitor her 28, 32, 36 and 40?
No, ma'am, it depends upon the severity.
Again, exactly. You started off well by saying you will start monitoring at 28 weeks, and that is to know whether there is a macrosomia, and you will repeat one at 32 weeks. Subsequent monitoring
will depend on the severity of the control of blood
because
sugar.
You need this in many of your high-risk pregnancies. Subsequent monitoring, this is a jargon, will depend on the severity, of the condition and the what your baseline values are. If at 32 weeks there is macrosomia, then of course you will monitor more frequently. Maybe you will do it once in 2 weeks and then switch to once a week. You may even do, if the sugars are totally uncontrolled, you may even do 2 times a week, right? Because you need to deliver at the appropriate time. Whereas if they are well controlled, you may do it only once in 2 weeks and maybe once a week in the last trimester. Okay, so subsequent monitoring, that's what you need to say. You need to monitor the fetus with the biophysical profile, including and the non-stress testing. We will do one at baseline at 38 to 28 weeks and repeat at 32 weeks. Subsequent monitoring, the frequency will be decided. Severity. Absolutely. Okay, so you've done all this. Yeah, Dr. Mary wants to know how will you deliver, what will you do, etc.
When will you deliver? When will you deliver?
Ma'am, if the sugars are under control, at around about 40 weeks we deliver. We don't allow them to go.
Pre-gestational.
Ma'am, pre-gestational 38 weeks.
Control. Control. That's control.
37 uncontrolled. Ma'am, I didn't get your question. Uncontrolled, less than 37 weeks. Giving
there are two groups. They can be controlled or uncontrolled.
37 weeks.
37.
Ma'am, depending upon the severity, ma'am, I will.
Yes,
36 weeks. Any fetal compromise, we will give corticosteroids and deliver before 37 weeks.
What will you do when you give corticosteroids?
Ma'am, there will be hyperglycemia, ma'am. We have to increase the dose of insulin, ma'am. We have to admit the patient and increase the dose of insulin.
And do your monitoring regularly.
TFMC, NST.
Yeah, you could. Okay. Then
you were saying something about corticosteroids. When did you say you will give it?
Ma'am, if it is associated with fetal uncontrolled, ma'am.
Uncontrolled, okay. What gestational age?
34 weeks.
Less than, only if you are delivering at less than 34 weeks. Please remember the late preterm corticosteroid, that is after 34 weeks up to 37 weeks, the trial did not include gestational or pre-gestational diabetics, and therefore we do not know whether the complications would be much more. So there is no recommendation to give it after 34 weeks in diabetics. Okay, the rest of them, there is this controversy. You want to give it up to after 34 weeks, before 34 weeks, a different matter. But in the pre-gestational diabetics were not included in the trial, and therefore there's no bottom line. So you certainly give it for preterm labor, or you're going to deliver them before 34 weeks. Okay, because after that we don't know whether the abnormality in the glucose abnormality will worsen and whether it is indicated or not. Okay, right. So what is the so you have well controlled, not well controlled, and with complications. Okay, well controlled is around 38 to 39 weeks, not well controlled is around 37-38 weeks. If complication, depending on when the hypertension goes up, you manage it as preeclampsia or hypertension. If the sugars are very much under, if there is fetal growth restriction because of a nephropathy, she has got a vasculopathy or a nephropathy, and there is fetal growth restriction, depending on the abnormality on the ultrasonography, you will decide on the delivery. And in those situations are when you decide on the steroid or not. Okay. Elective section. Sorry, Dr. Mary, you were going to ask something?
Labor. Okay. Labor. What are you going to do? How are you going to monitor in labor?
Ma'am, when patient is in labor, the morning dose of insulin is skipped, ma'am. And the labor, the insulin requirement comparatively decreases, ma'am. So first we'll start one will start the main line of normal saline, ma'am, and is piggybacked with dextrose, ma'am. At a rate of around 125 ml per hour, we will be supplying the glucose, ma'am. Then what is this? This is given so that the volume expansion is prevented suddenly in case of any anesthesia is given, ma'am. So 125 ml per hour will be given. Then every hourly blood capillary monitoring is done every hourly, ma'am.
No, this patient is on insulin. You have to start from the beginning. This patient was on insulin. So what do you do? Well, you induced her at 38 weeks. So what are you going to do?
If we are inducing that day morning, she can have a regular food and that insulin.
No,
is that how it is? Is that how it is? Is that how it is?
You said earlier that you will skip the morning dose.
Ma'am, morning dose is skipped, ma'am.
Absolutely. So how come you have changed now that she will have regular food?
No, ma'am. During induction, if she's just
even during induction, it is the same. Why? How is it different between spontaneous labor and induction?
Sorry, ma'am. Sorry.
Yeah. The previous night they have their full dose of insulin or medication. And the morning of the induction or delivery, they skip
insulin is
skip the insulin, do a
continuous glucose
estimate the
monitoring.
glucose level. If look here,
Less than 120.
continuous glucose monitoring, I don't think many of us have. So you monitor the fasting level, and then you keep repeating at regular interval. If the sugars are very high, do it every 2 hours. If the sugars are only moderately elevated, do it every 4 hours. Monitor with the frequency that is required. And in this 125 ml per hour or whatever you are giving her, take 5% dextrose, you have to add
regular insulin
ma'am, at the rate of depending upon the blood sugar, ma'am. If it is less than,
what is the blood sugar level you want in labor?
More than 120, we will give insulin, ma'am. Less than 120 is the
you need to maintain it at less than 120.
120.
Why you want it that way? Why don't you want it little more? What will happen if you want 140, 150, 160?
Ma'am,
why do you want to keep it at 120 only?
Ma'am, patient will hyperglycemic keto.
Baby will have.
Sorry.
No.
Baby will have.
Baby can go in for fetal hypoglycemia.
Ah.
So that is why you would like to keep it at 120, not let it go more. Okay, then.
Fetal hypoglycemia, the risk of fetal hypoglycemia is higher if the intrapartum blood sugar levels in the mother is not kept under 120. Okay. It also depends on the control of sugars in the antepartum period, but this is another factor. Okay, so in order to avoid severe neonatal hypoglycemia, you need to, yes, okay, right. Yeah.
Then according to the blood glucose, we will be giving the insulin value, ma'am. If it is between 100 to 144.
Yeah, you could titrate it according to the value. Okay, blood sugar levels, you titrate it. There are people who use a sliding scale. There are people who monitor every 2 hours and adjust the dose of insulin. All right. Okay, so there are several ways of doing it. Okay, yes. And
ma'am, will we do the insulin dose usually reduces, ma'am, in the process of labor, ma'am. So continuous infusion. Dextrose insulin regimen should be followed, ma'am, during the during the delivery, ma'am. Post delivery, she should be immediately the blood sugar should be monitored for the next 48 hours.
What happens? Where is Shafa? I can't see her. Where is your friend? Okay. What happens to the blood sugar levels post delivery? What happens to the blood sugar levels in gestational diabetic on medical nutrition therapy?
Ma'am, blood sugar values in
postnatally.
Decreases, ma'am.
Nothing very much happens. Okay, it might decrease. Okay. If they have been, if they are gestational diabetics who've been on insulin or oral hypoglycemic agents, the levels will definitely crash. Why do the levels come down? Blood sugar levels.
Placenta
because the placenta separates, and the half-life of HPL is how much?
No.
Only about 20 to 30 minutes. Okay, and therefore as soon as the placenta separates and comes out, you find that the blood sugar levels can crash, and therefore she will not require any of this medication postnatally, but they will have to be, what is that?
Monitored.
No, they don't have to be monitored. The blood sugars have to be checked when
6 to 12 weeks.
Absolutely. Because they are gestational diabetics, so check the blood sugars at 6 to 12 weeks to see whether they are, over diabetics who have been unmasked in pregnancy. If on the other hand they were pre-gestational diabetics on insulin, the insulin requirement will decrease. And so check the blood sugar, perhaps half the levels of insulin that is administered, check the sugar levels, and perhaps go back to whatever was being given pre-pregnancy. And you could even start the oral hypoglycemic agent. Metformin, both are quite acceptable postnatally. What contraception?
Barrier method of
why barrier? Do you know the failure rate?
No, ma'am. Low dose oral contraceptive pills will be
pre-gestational and gestational diabetes. In gestational diabetes, what will you give?
Ma'am, low dose oral contraceptive pill, progesterone injections, IUCD.
Intrauterine copper containing.
You give IUCD in gestational diabetes or not?
Yes, ma'am.
In gestational
You can give.
diabetes, we can give.
You can give.
Okay. What about in pre-gestational?
Ma'am, they'll be more prone for infection, ma'am. So they are comparatively.
And the
kept
efficacy
there.
of the IUCD will be reduced in pre-gestational diabetes.
Because of infection.
The
Then is also not.
none of these are there is no increase in the risk of infection, and there is no alteration in the efficacy. All these are acceptable, except that if they also have a vasculopathy,
No
if they are
OCPs.
pre-gestational diabetics with vasculopathy,
Vasculopathy.
and
Anema.
you might want to avoid estrogen progesterone high dose
well.
combination. Otherwise, IUCD is acceptable, long acting whatever contraception is advisable. All these can be. No, oral contraceptives are not contraindicated in lactation. There was somebody's asking. There was a worry. They are both glyburide as well as metformin are secreted in breast milk. They are transferred through breast milk, but the levels are very low, and neonatal hypoglycemia because of this is not common, and therefore people are okay with starting it in the lactating mothers. All contraception except in those with the vascular complications, I think
No
all
OCPs.
can be.
வாஷிங்
Do
மிஷின்
you
ஒர்க்
agree, Dr.
பண்ணல
Mary, that
Yes.
IUCD, long
இதுவும்
acting,
ஒர்க்
reversible,
பண்ணல
all of them are
நமக்கு எரிஞ்சிருச்சு
acceptable in
ஆள்
both
வந்துருக்காங்க
these?
சரிப்படுத்த
That is the wrong
நிறைய
notion.
வேலை
I wanted to ask the PGs
ஃபுல்லா போட்டு தொடச்சு
that you should not give IUCD for either of them.
எல்லாம் தொடச்சு
Gestation. It is not like that.
It is not.
You can give. Okay.
Okay.
You can use. Okay. Now you said that the dreaded complication is shoulder dystocia. Okay. How will you actually predict this macrosomia? Is there any way of predicting it antepartum? I have 3 minutes, so I'm just going to ask the last question.
Ma'am, when there is prolonged labor, then when there is no restitution during delivery, the descent is prevented.
Okay, there's a prolonged labor, yeah, absolutely, and the neck gets pulled back, turtle neck, etc. Instrumental delivery, etc. Okay, that is predicting in labor. Antenatally, is there a way of diagnosing
When the
macrosomia?
bisacromial diameter is greater than 14.
Okay, so you could, and there is an AC, head circumference AC ratio.
circumference
But please
greater
understand,
nobody
all of them
Hardly measure
have,
a acromion.
yeah.
So an abdominal circumference would help.
More the chest to head ratio is increased.
Okay, so please understand that all these have a very poor sensitivity for predicting shoulder dystocia and even predicting macrosomia. So the diagnosis of macrosomia is based on estimated fetal weight. What is the definition of macrosomia?
Ma'am, when the birth weight of the baby is greater than 4 kg or greater than 99%.
99%.
Greater than 4 kg, greater than 4.5 kg is macrosomia. Greater than 90th centile is a large for gestational age infant. There is a difference in the definition, just like in the growth restriction, fetal growth restriction. Small for gestational, yes, is GA and fetal growth
less than
restriction.
3rd percentile is
So 90th is more than 90th centile. Of course, 99th is more predictive, but I'm saying by definition, more than 90th centile is large for gestational age, and fetal weight of more than 4 is type 1 macrosomia. Fetal growth of more than 4.5 according to the American standards is type 2. Okay, we cannot go with the same standards because our birth weights are lower. So we may even take 3.7 or 3.5 as cutoffs for macrosomia. Okay. Now, what is your opinion? Will you do a cesarean section to prevent shoulder dystocia? What are the situations where you would do that?
Ma'am, cesarean section are done during malpresentations.
To prevent shoulder dystocia.
Birth weight of the baby is greater than 4.5 kg.
Even 4 kg, especially. Sorry, Dr. Mary. You were saying
Not 4.5 is to
4
kg.
4 kg.
4 kg in Indian standards. Some, as I said, some even say 3.7. But not just that, you also look at the previous history. Has there been a macrosomia, has there been a brachial plexus injury or a shoulder dystocia in the past? There is no clear recommendation in those who are under 4 kg for a cesarean section just for the prevention of shoulder dystocia. You really have to individualize and decide. Okay, I think time is up, right? It's
Yes,
7
ma'am.
o'clock. Yes, exactly 7. Any questions that you need to? Any burning questions? Dr. Mary will be quite happy. Yes.
Thank you, madam, for the nice
Okay, if not,
interaction session.
yeah, thank you. If not, you both did well. Be very clear in your answers. No confusion should be there in your mind. What is screening? What is DIPSI? What is WHO? What is OGTT? What is GCT? Gestational, pre-gestational, very clear cut. You should have a very good idea before you go for your exams. Okay. Right. What are the cutoffs for diagnosis at 6 weeks are the same as the non-pregnant women. Okay, GTT. Okay. How often to monitor during antenatal steroids? Well, you're going to give it only for those 24 hours, and therefore you need to do monitoring morning, the usual fasting, postprandial, etc. throughout that day and the next day, and manage accordingly. All right. Thank you. You both did well.
Thank you,
All the
ma'am.
best, all of you.
All the best,
Thanks a lot, Dr.
Thank you,
Shashikala
Lakshmi
and the
ma'am.
team.
Thank you.
Thanks, Dr. Mary.
Thank you,
It
madam.
was
Thank
good.
you.
Okay,
Thank you,
thank
Dr.
you.
Lakshmi ma'am and Dr. Mary Daniel ma'am, for the insightful and the excellent session. I'm very sure that all the postgraduate students would have benefited from this session. And thanks, Dr. Nikita and Shafia. It was a very good presentation. And with this session, we have come to the end of today. It was a remarkable session. I thank the organizing co-chairperson and the chairperson and the organizing committee for all their help. Tomorrow, we would like to gather at 10